I'm going to talk about paraneoplastic conditions. Atlas of Oncology by Dr. Muhammad Eid Zakaria, radiation oncologist, MD, DMRT, Jordanian Board in Clinical Oncology. And this is just only for doctors. Oncological problems. Oncology must always be dealt with in a multidisciplinary way, requiring teamwork between surgeons, internists, radiotherapists, clinical oncologists, medical oncologists, nursing staff, and palliative care experts. The knowledge of managing patients with oncological problems and emergencies, along with the methods of dealing with cancer complications, is essential. We emphasize on the management of problems in practice of specific tumors. This is also important for our residents and newly qualified clinical oncologists to become familiar with such oncological problems. Causes of cannonball pulmonary metastases. Which cases have cannonball pulmonary metastases on the chest X-ray? It is seen with osteogenic sarcoma or follicular carcinoma of the thyroid, malignant melanoma, chorion carcinoma, testicular carcinoma. And you see, this is osteogenic sarcoma and osteogenic sarcoma. This is melanoma. This is melanoma before radiation and after radiation. And this is cancer of the thyroid gland. And these are the paraneoplastic syndromes associated with lung cancer. You can look at this picture, and all the paraneoplastic syndromes with lung cancer are here in this picture. Causes of cannonball pulmonary metastases: also the prostate and some GI tract cancers, some very advanced nasopharyngeal tumors like this. You can see that there is a very huge lymph node here and protrusion of the cancer from the left nostril, and this was nasogastric carcinoma, and from the breast and from the kidney and from kidney malignancy. Now we look at causes of bone metastases. Cancer lung gives lytic lesions in bone like this and like this. The breast, 95% of the lesions are osteolytic lesions. Then the kidney, osteolytic lesions, prostate, osteoplastic lesions, multiple myeloma, thyroid, and melanoma. All these cause metastatic bone disease. Causes of lytic bone metastases. Now we look at lytic bone metastases. The lung gives lytic lesions, the breast 95% lytic lesions and only 5% osteoplastic. The kidney, which gives lytic lesions, prostate, osteoplastic lesions, multiple myeloma, lytic lesions, thyroid, lytic lesions, and melanoma, lytic lesions. Subcutaneous nodules are seen in lung malignancy, in GI tract malignancy, breast cancer, and some squamous cell carcinomas. You can see here carcinoma of the floor of the mouth, here subcutaneous metastasis from CA lung, and here cancer of the breast, and this subcutaneous mass is from CA breast, and this is carcinoma of the esophagus. The CNS metastases. What are the causes of CNS metastases? We have lung cancer, breast cancer, lymphoma, melanoma, chorion carcinoma, and thyroid carcinoma. Neck node metastases. Now we look now at the neck nodes. Here are the groups of lymph nodes. Here, this is one group, this is another group, and this is another group, and this is another group. So 1, 2, 3, 4, 5 groups of lesions. And nodal regions in the neck, we call them cervical. We have the jugular, we have the periauricular, the subdigastric, the jugulo-digastric, and supraclavicular lymph nodes. Neck node metastases happen in oral tongue, floor of the mouth cancer, oropharyngeal cancer, base of the tongue, tonsillar fossa cancer, soft palate cancer, retromolar cancer, hypopharynx, hypopharyngeal cancer, nasopharyngeal cancer, salivary glands, parotid, thyroid, lung, lymphomas, leukemias. All these give rise to neck node metastases. And malignant causes of lymph node enlargement. We have leukemias, CLL, lymphomas, Hodgkin's disease, non-Hodgkin lymphoma, Burkitt's lymphoma, other non-Hodgkin lymphoma, Sézary syndrome, this is Sézary syndrome, which is erythroderma plus generalized lymph node enlargement, T-cell, this T-cell lymphoma, immunoblastic sarcoma, it's rapidly fatal, and malignant histiocytosis, also it is rapidly fatal. Metastatic neck nodes also are common primary sites in nasopharyngeal cancer, in oropharyngeal cancer, vallicula, base of tongue and oral tongue, tonsil and facial arch, oral cavity, floor of the mouth, and soft palate. All these give rise to metastatic neck nodes, and they are common primary sites. Again, metastatic neck nodes also can be seen in laryngeal cancer, the aryepiglottic fold, the epiglottis, the hypopharynx, piriform fossa, lip, orbit, cheek, skin of the face. All these give rise to metastatic neck nodes. We are still in the metastatic neck nodes. They can happen in maxillary antrum carcinoma, salivary gland, which is the parotid. This is a case of salivary gland tumor before radiation and here after radiation. And here is a very advanced nasopharyngeal carcinoma. This is thyroid carcinoma. This is lung carcinoma, and this is rhabdomyosarcoma. So cervical, esophagus, thyroid, lung, pediatric soft tissue sarcomas of head and neck. The most common causes of supraclavicular lymphadenopathy is cancer of the breast. You can see here a dimple, in Arabic taqa'ur or ghammaz, and here is mammogram with cancer here, and this lady has breast cancer with this very huge supraclavicular lymph nodes before radiation and here after palliative radiation. We have metabolic problems as well. They happen in acute renal failure or nephropathy or urate nephropathy or hypercalcemia, hypocalcemia, and hyponatremia. Acute renal failure causes. What are the causes of acute renal failure? Tumor invasion of the kidney, such as leukemia or lymphoma. External obstruction of the kidney or ureters due to retroperitoneal nodes, or bulky uterine carcinoma, sarcoma, lymphoma, and testicular tumors. Obstruction of the kidney or ureters due to retroperitoneal cancer like cervix, ovarian, bladder, and colon. Acute renal failure happens also. Causes of acute renal failure: hypercalcemia, complications of treatment like chemotherapy with cisplatin, bearing in mind that the renal toxicity is a dose limiting factor for cisplatin, some antibiotics and antifungal agents, and radiation nephropathy. Metabolic problems, urate nephropathy happen in lymphoma, acute leukemia, and this is due to tumor lysis syndrome. This is due to large cell killing by using chemotherapy without the use of Xyluric. We come now to the hypercalcemia. It is common in advanced cancer, metastatic breast carcinoma, metastatic lung carcinoma, blood malignancies. Hypercalcemia must be looked at with albumin. Normal total calcium may represent hypercalcemia in a patient with hypoalbuminemia. Hyponatremia. Malignant causes of hyponatremia: lung cancer, lung carcinoid, pancreas, duodenum, mesothelioma, thymoma, lymphoma, and CNS metastases. Malignant causes or causes of malignant hypocalcemia: respiratory or metabolic alkalosis, excessive potassium loss in urine, renal acidosis, acute leukemia, antibiotics, villus adenoma, diarrhea, vipoma, medullary thyroid cancer. Causes of infections: infiltration of bone marrow by cancer cells, high-dose chemotherapy for bone marrow transplant, whole body irradiation, whole cerebrospinal axis irradiation, lack of immunity due to lymphopenia, and in neutropenia as a result of chemotherapy and radiotherapy. Other conditions which happen in malignancy: malnutrition, depression, bleeding, superior vena cava obstruction, like this case, spinal cord compression, and raised intracranial. Malnutrition. Causes of malnutrition: anorexia, malabsorption, anorexia due to the treatment. The causes of depression, based on 5-year study I conducted in Jordanian patients, are categorized into 3 groups. First group, the strong patient knows about the diagnosis, helps the doctor for his cure, and does not need antidepressants. Then we have the weak patient who always asks, do I have cancer? When I am going to die? This patient needs antidepressants. And the third kind of patient is the indifferent patient who does not want to ask you nor likes to be told. Causes of bleeding in malignancy due to chemotherapy, due to pancytopenia, very low platelet count, DIC in pelvic cancer, overuse of anticoagulants, tumor invading near vessel, tumor invading neck mediastinum with hemoptysis, colorectal ulcerative carcinoma, gastric ulceration due to chronic use of steroids, coffee ground of vomiting. Causes of superior vena cava. Here you can see a case of superior vena cava. Look at the dilatation of vessels here and the swelling of the face and neck. So it happens in secondary compression of the superior vena cava. Obstruction due to malignancy in the mediastinum. Large percentage are due to cancer of the lung, bronchial carcinoma, lymphoma, thymoma, leukemia, teratoma. Causes of spinal cord compression. Extradural compression due to collapse vertebral body by destructive process. Lesions such as metastases from breast, bronchus, prostate, multiple myeloma, non-Hodgkin lymphoma, nodal masses, even primary tumor, and hemangioma causing fracture, vertebra, and spinal cord compression. The causes of raised intracranial pressure caused by metastatic or primary lesions in the brain, source of metastases, bronchus, breast, testicular teratoma, malignant melanoma, non-Hodgkin lymphoma, primary intracranial new growth glioma. Also the medulloblastoma and ependymoma in children and young adults, primary cerebral lymphoma, pineal tumors and pituitary tumors, and choriocarcinoma. Thank you.